Good afternoon. Hello, it's Dr. Steve Vernino. I'm a professor of neurology at UT Southwestern Medical Center in Dallas. And it's our pleasure at UT Southwestern to help host this 2022 patient symposium for Multiple System Atrophy Coalition. And to kick off this initial session around the concept of multidisciplinary care for multiple system atrophy. And I'm joined in this session by my colleagues, Dr. Liz Kuhn from the Mayo Clinic and Dr. Nick McFarland from the University of Florida that you'll hear from in a moment. But I'm going to start with a little background about multidisciplinary clinics and multidisciplinary care for multiple system atrophy and how we went from the inception, the thought about this idea, to implementing multidisciplinary clinics around the country. So the objectives of my talk are to really very briefly discuss multiple system atrophy, then talk about the concept of a center of excellence or a multidisciplinary clinic and why that might be a good approach in multiple system atrophy. And then finally, we'll talk specifically about what we're doing at UT Southwestern in implementing this clinic model. So very briefly, most of us know that MSA is a relentless neurodegenerative disease that affects multiple systems, hence the name. And that include many of what I like to tell patients are the 4 or 5 Bs, problems with blood pressure, problems with balance, problems with bowel and bladder, problems with breathing and sleep, but usually not cognitive functions. If patients with these symptoms have problems with memory or thinking, that we think about other diagnoses. And then there are various clinical and imaging characteristics that help us make a more definitive diagnosis. So because this condition affects multiple areas and causes multiple types of symptoms, ranging from autonomic to balance symptoms, we often need multidisciplinary care. In other words, we need input from a number of different kinds of doctors, not just neurologists, but others as well. And you'll hear a little bit more from Dr. Kuhn about the various aspects of a center of excellence that might include 8 or 10 or more different specialists brought together to provide the best care. So the goal of providing this multidisciplinary care is really multiple. There are really multiple goals. One is to improve clinical care because if we have the best experts addressing the individual symptoms, we get the best outcomes. And that in turn should improve the quality of life of patients and their caregivers by reducing the burden on caregivers. By integrating multiple specialty care, we can think forward, we can be proactive in identifying problems that we anticipate will happen and getting some plan in place, for example, to involve palliative care options early in the course rather than waiting until there's a crisis. The multidisciplinary care model can also facilitate research by tracking patients on a regular basis to do both observational research, in other words, understanding the disease better over time, and interventional research by being able to recruit patients into clinical trials more quickly. And then we aim at least in our clinic and as a goal of multidisciplinary care, to improve the education for patients and their families so that they better understand what's going on and which doctors are expert in which aspects of the disease. And then because many of these multidisciplinary clinics occur at teaching centers at academic institutions, that this kind of care actually is very good for trainees who are learning about the autonomic nervous system, movement disorder fellows, neurology residents, palliative care fellows, and so on. We'll talk a little bit more about that. And then finally, by bringing together a system to provide multidisciplinary care, we make this more efficient so that many of our patients who have mobility issues and don't travel well can get the care they need in one day as opposed to coming to the clinic multiple times. So when we talk about MSA management, this is a list of the types of specialists that might be involved in care. We've got the neurologist, who is probably the one who made the initial diagnosis and provides the initial education about the disease. But sometimes we need help from a cardiologist or a urologist. Sleep and breathing issues can be important in MSA. GI problems affecting the gut, such as severe constipation. ENT for breathing as well as speech problems. Psychology is often important. rehab doctors, physical medicine rehabilitation that helps to coordinate the physical and occupational and speech therapy. And then we need a support team of nurses and medical assistants and social workers to really help some of the day-to-day difficulties that patients have, to help guide them and provide some supportive care. So at UT Southwestern, we had this idea that this was something that was needed. And back in 2015, with the help of some generous donors, we were able to put together a team to really run the first multidisciplinary MSA clinic. And this is our team from 2015. You can see I'm there. Also, I want to point out the person on the other end of the group here, Dr. Praveen Kamani, who was a Parkinson's and movement disorder doctor, one of my colleagues at UT Southwestern, who really was instrumental in hatching this idea. And he discussed this at a previous MSA Coalition symposium. And then a bunch of other people, other physicians, medical assistants, social worker, research coordinators, and so on. That's Dr. Kamani. This is Dr. Brierly, one of my former trainees, who's now a colleague and working closely with me in the MSA clinic. Steve Hopkins, one of the research coordinators, and Elizabeth Kent, our initial social worker, who was really important in putting together some of our structure. So again, this takes time, it takes cooperation, but it also takes money because many of the services we provide aren't typically provided by or funded by Medicare. And so we are grateful that Mr. Reed and his family, Rex Griswold and his family and foundation put up some money initially to help get this clinic started. And that was really the key linchpin that got it going at UT Southwestern. So we've been having a multiple system atrophy multidisciplinary clinic at UT Southwestern now for almost 7 years, and 121 MSA patients have participated. Some have died. Many of them have agreed to donate their brain to research, and that's an important and very valuable resource, a way for patients to continue to give back even after they've died. And we usually run about 40 patients who are active and seeing us on a regular basis. The MSA clinic has allowed us to do clinical trials for MSA and rapidly recruit patients. We've added beyond just the clinical care that's provided during the monthly MSA clinic. We also aim to provide support and education for patients. So we've had a monthly patient support call for patients and caregivers, as well as regular education conferences on various topics that are of interest to patients and their caregivers. And those have been organized by Chidima Nguma, who's our nurse practitioner that works with our patients. Fortunately, we have now Zoom and other video conferencing technologies. So at these patient support and education conferences, we're able to continue despite the COVID lockdown that we've had over the last few years. And we also learned how to use virtual visits or telemedicine to reach more patients. So one problem we had in the early days of the MSA clinic is that eventually many of our patients would get too disabled and have too many mobility problems to really get to the clinic for their regular appointments. And we were able to use telemedicine and continue to use telemedicine to stay in touch with them and provide some ongoing assistance even when they can't come in person. And as the clinic has grown, we've gotten additional support through grants and endowments to continue this work and continue to expand it. But it's a dynamic process. So we wanted to make sure, as we kicked off the multidisciplinary clinic, that patients and their caregivers provide feedback to help us improve, continue doing what's working well, and improve on what could be doing better. And so we asked patients for their input. And interestingly, right at the beginning, we tried to do everything. We tried to get all the specialties to see all the patients at every visit. And that ended up being a 4 or 5 hour clinic visit for patients. And they found that that was too long. So we actually pared down our core group of providers that patients see every time. And then the rest of the team gets to see patients on kind of an as-needed basis. We brought in better counseling opportunities for patients that need that. We've provided some separate caregiver support group because caregivers remarked that that was helpful for them. And we are working closely with both industry and others and other collaborators on the cure for MSA, which ultimately, hopefully, will make MSA multidisciplinary clinics unnecessary in the future. But I think that future is a little ways down the road. As part of looking at the outcomes, and this slide is too busy for you to really read, but we do collect information on quality of life from various symptom questionnaires, and this helps us really understand where the burden of disease occurs. This is data from our patient groups of over 100 patients, which was enlightening because it shows that some of the things that bother patients the most include things like initially when they first join the clinic, and of course balance and walking as being important things, but also loss of ability to do hobbies and help around the house. And those continue to be important issues, but later on, as the disease progresses and we look at the same questionnaire a year later, things such as mobility, balance, bladder issues start to become more and more prominent over time. So these sorts of questionnaires help us understand how the disease progresses, not just in terms of what we see as doctors, but how the symptoms affect patients' ability to do the things that they want to do and enjoy doing. So the current UT Southwestern multiple system atrophy team includes neurologists, both myself, Dr. Brierly, and our nurse practitioner. We represent autonomic neurologists, but we also have input from movement disorder and sleep neurologists who join the clinic. And these are fellows in training that come and work with us and learn more about multiple system atrophy and how to apply their particular specialty to these patients. We have palliative care physicians that join us and help, really very, very helpful in terms of guiding patients and their caregivers through this terrible disease and how to maximize quality of life and manage symptoms. The same with our physical medicine rehabilitation doctor, Dr. Ben Nguyen, who's in our clinic at every session and provides input about home modifications, wheelchairs, and safety. We have a nutritionist, Alicia Gilmore, and many of these people, by the way, you'll hear from over the course of the conference over the next day and a half. Very important to have nurses and medical assistants who know about this disease and how to help patients navigate through the clinic. We have a research team that coordinates the collection of data and enrollment into research opportunities. And finally, a social worker, Sheila, who's been invaluable in guiding patients to resources that are available to them in the community or through their insurance, and also providing counseling services when needed. So I'll later on in this session, I will give you a brief tour of our MSA clinic and how it works. But the process of the clinic involves several steps. We start with a pre-visit survey in which the patients are able to give us some idea of the things that they're worried about for the upcoming clinic session, so we can appropriately schedule the right people to see them. We also collect research questionnaires to advance our research mission. The patients come and check in. An important part about our clinic is that we check blood pressures very carefully. We scan the bladder because urinary retention can be a serious complication of multiple system atrophy and can sometimes sneak up on us and lead to urinary tract infections and so on. But if we can identify urinary retention early, we think that we can prevent hospitalizations and infections. And we always review the medications carefully to make sure we're not using medications that are making things worse rather than better. In the MSA clinic, patients always see their neurologist. They usually see the nutritionist and the social worker and the research coordinator. And then the other visits with rehab, with palliative care, with the sleep doctors are guided by the patient's answers to the initial survey that they completed before coming to the clinic. Then we can coordinate as needed clinic visits on either the same day or close by in the calendar with urology or ear, nose, and throat doctors, physical therapy, and so on. So that's how the clinic runs, and I'll walk you through that later this morning. Just as an example, the pre-visit survey includes most of the things that MSA patients worry about, and this really helps guide us in terms of what's really the main issues, because multiple system atrophy affects multiple symptoms, multiple systems, and it can be a long interview to try to go through all of these separately. So the patient's pre-visit survey guides us toward the things that are bothering them the most, and we can make sure to focus on those when they come to our clinic. So that's a little introduction to where we are now at UT Southwestern in terms of our MSA clinic. Thank you for your attention. And next, I want to introduce my colleague from the Mayo Clinic, Dr. Elizabeth Kuhn, who's going to tell you a little about a little bit more in more depth about the individual components of a multiple system atrophy center of excellence.